the Light Symposium. We rheumatologists, we try to meet the challenge of raising the bar in rheumatoid arthritis management, and we will have the opportunity to share practice issue with two experts, Dr. Imad Uthman, Professor of Clinical Medicine, Head of the Division of Rheumatology at the AUB Medical Center, and Professor Hussein Halabi, Consultant and Chairman of Rheumatology, Director of the Academic and Training Affairs at King Faisal Specialist Hospital and Research Center in Jeddah, Saudi Arabia. So, please, Dr. Uthman.
Thank you, Mr. Chair. What we try to do today is to go briefly over the comorbidities that occurs in association with rheumatoid arthritis. As you know, rheumatoid is a disease that affects primarily the joint, but because it's a systemic autoimmune disease, other organ systems in the body are involved, and we should be careful about the involvement of other organs whenever we follow up patients with rheumatoid arthritis. So rheumatoid arthritis, it's a quite prevalent disease, and the incidence of this disease, or the prevalence is around 1%. In the US, 2.5 million Americans are affected with rheumatoid arthritis, mostly female. It's a chronic, progressive, and quite disabling disease with higher mortality rates as compared to the general population. And it's estimated that the lifespan of patients with rheumatoid goes down by 3 to 18 years over the lifespan of the patient. And with a high cost to the third taxpayers, to the government, so it's quite disabling, it's quite costly. Rheumatoid can affect all age group, from pediatric patients to elderly patients, but it's mostly a middle-aged disease of the middle age, predominantly female patients. So, as I said, although the central pathology of rheumatoid is the synovium, however, non-articular organs can also be involved, and patients with severe disease are expected to have other organs involved, like we see now, the bones, the heart, the kidneys, the lungs. So, a long list of extra-articular manifestations are seen in patients with rheumatoid arthritis, namely bone problems like osteopenia and osteoporosis, muscle weakness, skin disease, eye disease, lung disease. So, every organ system in the body can be involved with rheumatoid arthritis, and as I said, we should be careful about following up these patients in order not to miss any of the other extra-articular manifestations of rheumatoid. As for osteopenia, it is definitely associated with RA, and it's caused by the combined action of the prostaglandins and cytokines, and in the absence of anti-absorptive therapy, all patients with RA are expected to have a higher rate of bone loss as compared to the general population. So, the decrease in bone loss is not only stated to glucocorticoid treatment. The disease by itself is associated with higher incidence of bone loss, and there is an inverse association between the measurements of acute phase reactant and bone mineral density. The higher the acute phase reactants, the more bone loss we expect. Osteoporosis of the hips and lumbar spine is quite common in these patients. In a study on 287 Norwegian patients, among whom the prevalence of osteoporosis was found to be 22%, and most tests of osteopenia and RA also include preponderance of women, and also men with disorders have a higher incidence of osteoporosis. In another study, 94 men with RA compared with population control, there was a twofold increase in osteopenia among these patients. So we should carefully follow the bone density in these patients, even if they are not taking steroids, because the disease by itself, inflammation, will increase the rate of bone loss. Muscle weakness, very common in patients with rheumatoid, and should be also carefully followed up. And several etiologies can explain the muscle weakness. First, synovial inflammation leading to decreased joint motion, which rapidly produces reflex atrophy in the muscles around the involved joint. So, the first cause of muscle weakness is basically synovial inflammation leading to less movement of the joint and muscle weakness. Myositis, in certain autopsy series, accumulation of lymphocyte plasma cells have been documented in muscle fibers of patients with rheumatoid arthritis. It was called as nodular myositis. Vasculitis, another cause of muscle weakness in patients with rheumatoid arthritis. And finally, drug-induced myopathy, predominantly secondary glucocorticoid. Any patient who receives steroid treatment for a long period of time is expected to get steroid myopathy. Anti-malarial drugs rarely cause muscle weakness, but we should keep it in mind whenever we evaluate patients with muscle weakness, with rheumatoid arthritis. Statins also can be considered. So drug-induced myopathy in the context of rheumatoid arthritis can be multifactorial, basically because of the disease and also because of drugs used in the treatment of this condition. Now we come for the skin manifestations. Rheumatoid nodules is the most common cutaneous manifestations of rheumatoid. Can be present in up to 35% of patients, and almost all nodule formers have a positive rheumatoid factor, common seen at pressure point, but can be formed anywhere in the body in these patients. Other less frequent skin manifestations include skin ulcers because of multiple etiologies, and neutrophilic dermatosis, which is sterile infiltration of neutrophils in different areas of the body, also called Sweet syndrome. So other than rheumatoid nodules, skin ulcers and neutrophilic dermatosis can be seen in rheumatoid. Also skin disease secondary to drug-induced or drugs used for the treatment of rheumatoid, basically glucocorticoid, chronic use of glucocorticoid can lead to skin atrophy, and also Raynaud's phenomenon, which can be seen in so many connective tissue disease, basically tissue scleroderma, but also can be seen in lupus and rheumatoid. So it's another cause of skin disease in patients with rheumatoid arthritis. Now the eye is an important organ commonly involved in rheumatoid arthritis, especially in the juvenile variety, where episcleritis can be considered as extension of synovial pathology in rheumatoid arthritis. They occur in less than 5% of patients. Episcleritis causes acute red and painful eye without discharge, whereas scleritis causes deep ocular pain and dark red discoloration. Keratoconjunctivitis sicca, or dry eyes, can be observed in association usually with the Sjogren syndrome. Lung-wise, there is many pleuropulmonary manifestations of rheumatoid arthritis, basically rheumatoid-associated lung disease, drug-associated lung disease, and infection secondary to immunosuppression. Interstitial lung disease can be seen, and pleural disease also are commonly associated with rheumatoid arthritis. So interstitial lung disease and pleural disease are the most common forms of lung involvement in rheumatoid, and we see every now and then patients present with pleural effusion and who later on develop the joint manifestations. So pleural effusion can be the first manifestation of the disease. Interstitial lung disease is the most common manifestation of rheumatoid lung disease. The clinical presentation, pathology, and disease spectrum is similar to idiopathic interstitial pneumonia, and histologically the abnormalities are highly variable, but basically there is resembles those of interstitial pneumonia, idiopathic interstitial pneumonia. Pleural disease, common, but usually subclinical, and it's quite common in patients with long-standing RA, and as I said, it can precede joint disease, and I believe all of us have got patients who may have presented with pleural effusion and later on developed joint